Hi, everyone, and welcome to the Vascular Spotlight. I'm with Dr. Srini Tummala. He is a vascular specialist in Miami, Florida. Recently, he wrote an article called Pedal Artery Revascularization. Is it ready for prime time? Pedal loop revascularization is something that I promote with all of the patients that I support around the world. Why? Because nearly 200,000 amputations occur annually. That's even in the US alone. And one of the biggest reasons is they can't get blood flow to the foot. Only 10% of vascular specialists in the US actually are skilled in revascularizing or restoring blood flow to the small vessels in the foot, which are critical to saving life and limb. Dr. Tummala is one of those doctors, one of the 10% of specialists across the country that perform this type of procedure. Dr. Tummala, thank you so much for coming on to discuss your article and why the pedal loop is critical to saving life and limb.
Thanks, Kim. It's a pleasure to be with you and talk about this really important topic.
So first off, why is the pedal loop so important? And even going back a little bit, what is the pedal loop? It's in the arch of the foot, small vessels down there in that foot.
So I think when people think of blood vessels, I think they know that arteries take all the blood flow from the heart to all the muscles and tissues in the brain and everything throughout the body. The pedal loop is really, think of it as the last drainage pathway or outflow of the foot. So without it, it doesn't matter how great the pipes are from the groin or the heart or the knee down. You really need to have a good pedal loop so that blood flows normally to the toes and the tissues in the foot. Otherwise, it really puts patients at risk for amputation, as you can imagine.
When did, I would say, the majority of that 10% of those vascular specialists begin doing this? When did it become such a real point that these doctors are trying to make with the masses and saying this is a must?
I think pedal loop interventions, have been around for several decades. I think it was really 2009 when a lot of the early publications came out talking about safety and feasibility, just meaning that an intervention or a fix of the blood vessels in the foot or below the ankle could be performed safely, and that it was something that could be consistently done or reproduced. And then a decade later is when we got a lot more information about really the importance of it. We're still waiting for really good randomized control trials. So basically the best type of study you can have out there, called an RCT or randomized control trial, we really need those to really prove the technique. But I think it's been shown over and over in all the other studies in the literature that we've done, since 2009 onward, that it is a safe and something that should be performed in certain patient groups.
It's safe as long as you have those skills in order to get into those small vessels, because
Right.
it can be dangerous. They're small vessels, they're very fragile, and especially when they're highly stenosed.
Yeah, I think what's happened is, over the years, a lot of people were kind of, they didn't want to really take on this new area for fixing patients and treating patients with, who are at risk for amputation, mainly because, like you said, the risks are high. There's risks of rupture, of tearing the artery. There's risk of occluding or causing the artery to basically shut down. And all those things can really take somebody who may be, dealing with just pain or a small wound, and now all of a sudden they're basically at risk for really a major amputation because of the procedure. And so the more skilled, the more the experienced the physician in this area, the better off the patient is.
And there are more and more tools coming onto the market these days that are making it easier and less so-called radical, as some will say, in going into the foot.
Yeah, no, I think so. I think over the past decade, there's been really an explosion of technology, whether it's smaller catheters, wires, angioplasty balloons, and things like that, that really let us, really access these vessels and give us the tools really needed to perform, successful fixes in this area.
I remember I was in Germany, and one of the doctors that I was observing had gone pretty far. It was a 94-year-old woman. He had restored flow to get her by. But another doctor in the room said, oh, hey, I had this device. It's called the Phoenix. Have you ever tried? Do you have it? He's like, yeah, I have it. I don't really use it very often. Oh, no, you got to try it right there. Get it into the foot. It's right there in the ankle. You got to use it. So here was this woman. He had saved her leg and her foot from amputation, got as far as he could, got just enough flow to get this 94-year-old woman to at least be able to walk and sleep at night. And here's this other doctor says, hey, do this. You can go even further. I couldn't believe my eyes. He went in. I mean, you don't go into a foot. I mean, when you rarely use the device anyway. And it just right before our eyes just munched the artery and she had to be sent to amputation. It was really sad. So it does need to be taken into consideration whether it's worth the risk or whether you need to go into the foot, don't you think?
Yeah, and I think that's what the whole, impetus for me to really review the literature and publish this short, kind of research article or review article is that I wanted to see kind of where we were with the science and the literature. And like I said, we've shown safety, we've shown that it can be done, consistently by experienced operators. The technology has improved tremendously over the past decade. We still have a long way to go. But I think at this point, we've shown that there are certain instances where, treating the pedal loop or these below ankle arteries is advantageous to a patient, namely in terms of quicker time of wound healing and also a better wound healing rate. Those are the two areas that we've shown that's shown promise.
And no matter what, if a patient is facing amputation, you've got to exhaust all efforts. And so if you're going to amputate anyway, isn't it worth the risk to see if you can actually get into these small vessels and restore some flow to give that patient the greatest hope and possibility of living a better quality of life?
Yeah, absolutely. I think in cases where patients are really going to be scheduled for an amputation, you really have nothing to lose. And I think, seeing somebody who's experienced in this type of intervention or this type of fix, it makes perfect sense for them to really tackle the pedal loop if it's needed to restore blood flow to the limb. No doubt about it. No doubt about it.
It's interesting. There are different schools of thought around the world. You have some doctors in other parts of the world that say, we're not going to touch a patient, especially the foot, unless we see tissue loss. And then you have other doctors here in the US that say, oh, no, you need to get it to prevent tissue loss, which ultimately results in permanent nerve damage in many cases.
Well, I think the way to look at it is that, it's really not an art. There's no guessing here. I mean, there are really well-published guidelines on when to intervene, when to try to fix, and so forth. And I think, most skilled operators try to follow those. If somebody just has pain in their foot and that's it, and they've got some vessels below the knee that need fixing, you can fix those tibial vessels or those vessels between the knee and the ankle and leave the pedal loop alone. And usually that pain will go away. Or if there's more proximal disease, meaning, disease above the knee, fix that and see how they do. I think if they've got wounds or tissue loss and so forth, then you can fix everything down to the ankle to try to improve the blood flow. And if it looks like the flow is not good because of a badly diseased outflow, right, which is the pedal loop that you've been talking about and we've been talking about, then you need to tackle the pedal loop in those cases. But I think you just have to be very careful, very selective, and really try to follow the best evidence and data that's out there when doing it.
How can we get more hospital vascular specialists to do these types of procedures? Is it a matter of getting the administration to order more, more tools that are longer and smaller that can reach into the foot?
Yeah, it's not a matter of tools. I think what it is, it's a matter of experience. A lot of vascular doctors across the country. I mean, I do a lot of courses for various doctors in different specialties. And a lot of them don't have a lot of experience with anatomy, even the basic anatomy below the ankle, because it's not something that has gained widespread adoption at this point. And the reason for that is because of the risks that are involved in terms of complications that can occur. So, and so if you're not experienced and then you have to deal with it, most patients, and then they don't know who to refer to or send to. So now you can see how that puts a patient at risk for an outcome that perhaps, could have been averted. Perhaps. We're not always sure, because remember, even though we fix the pedal loop, it's not a perfect solution in the sense of everybody does well. Sometimes you fix it and nothing changes. So.
Right. I just had a patient that was treated by a very well-known vascular specialist, and he was asking me, well, what is the long-term patency for pedal loop revascularization? And what are the keys to ensuring that a patient is going to have long-term patency when they have their pedal loop revascularized?
Well, I think the way to look at it is, I think most people have been quoting about 50% patency rate after angioplasty. There's not tons of data out there, but there is some. So we know it's safe. We know it's feasible. We know that there is some level of patency rate. However, we also know there's a high risk involved, right? So that's why tackling the pedal loop, we really shouldn't, unless you're very experienced and in specific instances where it makes sense based on the patient's anatomy and what's going on with them clinically.
I would think when it comes to pedal loop revascularization that a vascular specialist would want to have a very close relationship with a podiatric surgeon, podiatrist, someone who specializes in diabetic wounds in particular, so that there becomes a very synergistic relationship in making sure, hey, we're going to restore blood flow to those wounds. Now we need the debridement happening, and we need to both work as a team and collaborate to ensure this patient can heal a lot faster.
Yeah, no, you're absolutely right. And most of us that deal with critical limb ischemia or patients with wounds and so forth, we have really close relationships with not only podiatry, but also infectious disease doctors, because a lot of these patients will have infections that need to be treated, with nephrologists, because a lot of them may have, kidney disease or kidney failure that could be a contributing factor to their really bad peripheral arterial disease, or P.A.D., as well as a host of others, plastic surgeons, as well. And so there's a good synergy, and most good vascular doctors will try to form these alliances to have really a multi pronged approach to treating these patients, because it's not just fix the pipes and then let them go.
And what do you think about new technologies that help to bring a little bit more flow into the foot, such as limb flow? I know that it's a technique. They've packaged, right, a bunch of tools that many vascular specialists who do pedal loop revascularizations and such have already used for a very long time. And in particular, to reroute the blood from the artery to a vein to restore flow to the foot. Do you think that will help make these types of foot revascularizations, for lack of a better phrase, more mainstream in hospitals?
Yeah, I think the way to think about it is, remember that, we're talking about fixing the pedal loop, but if the branches coming off this main highway, even in the foot, are blocked or diseased or completely closed off because of diabetes or chronic kidney disease or the combination, it doesn't matter how normal or pristine the pedal loop looks like below the ankle, their tissues won't heal. And then so that's called the so-called desert foot, right? And so what limb flow is basically a way to increase blood flow to the tissues via the veins. So basically you're creating a conduit around a blockage to the veins in the foot, to make it as simple as possible to understand. And then basically that increased blood flow is filling all the veins and then backfills all the tissues to give it oxygen and hopefully heal the wound. So it's really for the end stage, no option patient who's tried everything and now they're like, there's amputation. We tried your pedal loop. It looks good or it doesn't look good. We can't open it, whatever the reason. And now we're at the nth hour where we have to do an amputation. This would be the next best. And it doesn't have to be specifically the company limb flow, which is, being studied in various trials, but it's all the tools that are available, commercially now that are FDA approved. A lot of people have been doing this for some time now, and now they're finally studying it as part of this kit, so to speak.
It's something that we need to get taught in vascular, doctor programs in school. I've had several students that have said, gosh, I wish I would have learned this. I wish it was in my textbook.
Yeah, for sure.
Because I've gone to a couple universities where the philosophy has been, if we can't stent it, we can't treat it. And you don't really stent down there, so they don't treat
Right.
it. And
Right.
that doesn't make sense to me anymore. These textbooks need to be revised, and these standard teaching protocols also need to be revised.
Yeah, I think the main thing is that, it just shows you how rapidly, this stuff is evolving, right? Whether it's technology, whether it's data, whether it's the information on how things should be fixed and how to treat these patients. And with this explosion of information, you can imagine by the time a textbook is written, there's already 2, 3 iterations of something else that could be included, and so it really is up to the vascular doctor or vascular physician to really try to read and keep up and go to courses and conferences and talk to experts around the country and the world to really keep up with all this stuff.
What I love about you is that you're not waiting for conferences. You're not waiting for scheduled webinars for the masses. You've actually created your own YouTube channel to really make it searchable. So when people are saying, doctors or even patients are searching for how to save my foot or how to save a foot, they can easily and quickly find your YouTube channel. Talk about the content. What inspired you, or what was the catalyst for you to start creating your own channel and your own videos frequently?
Yeah, I mean, it's something I started mainly because I wanted to get some of these lectures that I was giving to, a lot of the trainees, the early career physicians, and, anybody that really wanted to learn about peripheral arterial disease and all the techniques needed to fix things and treat these patients in a kind of a safe and expert way. And then slowly what started happening is it started gaining more and more traction. And so I needed to really kind of change the face of it. I had to actually put an actual trailer, a logo, make sure it looks professional. And so once I did that, you can imagine it started gaining even more traction from various companies and so forth who wanted me to create content for them. I've even got a presentation on what you're talking about, which is called deep venous arterialization, which, the limb flow is one product that can help do that. So the no option, patient who has no options left. And so I'm going to be putting that online pretty soon so people can, patients could probably see it, but it's geared more towards physicians right now or trainees. What you're talking about is Dr. Tummala's vascular channel on YouTube. So yeah, thanks for mentioning it.
And patients, how do they know, or what questions do they ask to determine if their doctor performs this type of advanced procedure to save their limb? We always tell patients, hey, you may not need a pedal loop specialist right now. You may not need a below the knee expert right now,
Right.
but if you're a diabetic, you will need it. You will need it at some point. So why not find someone who can treat you from waist to toe right now, even if they don't have to go to the extra lengths to save your foot at this moment?
Yeah, I think the main thing, what I tell my patients, or people that I know when they got to go see a doctor for something else is, go meet the doctor, meet the physician, listen to him or her, see what they have to say. But if anyone's telling you, look, you have no other options, amputation is the only thing we have left, then I think it's time for a second, maybe a third opinion until you get an answer of something that's from a reputable person that can be done. We have a lot of options now. No option for critical limb ischemia patients and patients with bad vascular disease really should not be the slogan of the day anymore.
So back to your article, are we ready for prime time with the P.A.D loop?
I think it is. I mean, I think there's enough early data, they call it short-term and mid-term data, that says that it is safe, it is feasible, it can be done. And I think we just need more experienced operators to really become, masters at this new in this new frontier to really save a lot of these patients who really have no other option.
Thank you so much, Dr. Srini Tummala, a vascular specialist, an advanced vascular specialist, I will say, in Miami, Florida, who wrote a great article called Pedal Artery Revascularization, Is It Ready for Prime Time?
Thank you, Kim. I appreciate it.